athletes and from colleagues and through education sessions like this. And I really want to stress and acknowledge the importance of the healthcare team. And what I really want to do is really a hands-on experience as much as we can through a webinar like this. Most of these slides and most of these pictures were taken yesterday with going through our EAP with the amazing team in Milano Cortina here in the Milan ice rink. So with that, I have nothing to I have no relative financial relationships, except for I have a little bit of a sled hockey bias. I've been with the team since 2012. And right now in our games, there are 6 main sports in our games right now. And you would say, look at all these, you'd say, some of these sports may be higher risk than others, with, para-alpine being very high risk for significant emergency scenarios and extrication, and sled hockey, not without risk itself. But I remember very well in Beijing, one of the main injuries was an upper extremity fracture in wheelchair curling, with the Team Canada sled physician helping as well when one of the athletes went off one of the ramps. And so we have to be prepared and really think about where these injuries could occur. And with that, when we talk about para-athletes, in my opinion, in my experience, the thing that is and as an ER doctor, one of the things that's so obvious and simple is that there's an underlying diagnosis and there's unique equipment. And so it's so important to have that as a consideration, as Wayne Derman mentioned in the introduction. So with that, the diverse group of athletes, right? A previous list of the IPC eligible impairments, these are what our athletes are competing with. The concussion and parasport group, where there's multiple people on this that helped put this out, identified 22 impairments, all right, that the SCAT-5 at the time wouldn't be applicable for, right? So it's a diverse group of athletes, okay? With that, the equipment is unique, right? This is one of our sleds from an athlete who was a bilateral below-knee amputee, and you have to understand how to get the athlete out of one of these things. The theme of unique equipment causing unique injury patterns is throughout adaptive sports, whether it's sled hockey or something with Dr. Earn up on the mountain. And the time to learn this equipment is not during the emergency, if that can be avoided. So if you are going to be slope side or rink side, you might not have the benefit of knowing the athletes because you've traveled with them or been with them for a period of time. You might be showing up, and not only do you not know your athletes, but you've never met your other team members. And this is the type of high-functioning team that we like to see and try and put together, because you're going to be taking care of athletes who look at you and say, how are you going to do it? What's your plan? What's your plan? And so with that, we can fall back on some training. And what we'll talk about in this lecture is our ABCs of trauma and expanding the D. And it sounds simple, but I want to explain to you more what I mean about that. Equipment extrication, I'm going to show you what we do for sled and have done for quite some time, and then we'll talk a little bit about the worst case scenario and something that is just an awful thing to experience. It's sudden cardiac death. And sharing with you what I've learned through true trial and error over the course of multiple years. So ATLS, approach to trauma, advanced trauma life support in the United States and throughout the world, right? And with that, it's a systematic way where you approach a trauma patient after a self-check and scene safety, where you have airway, breathing, circulation, and then in an able-bodied athlete or patient, right, you are looking at D, which is a rapid neurologic assessment, alert, responsive verbal, responsive pain or unresponsive, or a Glasgow Coma scale, or rapid assessment of a potential spinal cord injury. But for an adaptive athlete, one of the things that we talk about so much is expanding the D in the primary survey. It's so important to know some of these things that we talk about it in the primary survey. So we say the D also is expanded to the underlying diagnosis or disability, because the adaptive athlete can have an underlying diagnosis or disability that can impact the management of emergency or be the cause of it. And as we think about this, we can use neurologic diagnosis as an example quickly. And with that, does this athlete have a risk for autonomic dysreflexia? Are they insensate and we could be missing a major pelvic injury? Is there spasm that we'll have to consider while we're thinking about spinal motion restriction? Skin integrity. We don't want to be the cause of a skin breakdown or skin injury. Orthostatic hypotension, thermal regulation up in the mountains with Dr. N, and then contractures. And with the contractures, I want to share with you quickly an experience that we actually had in October in Oosterhout, one of our competitions. First day, first practice, an extrication challenge out of this sled with an athlete who's got caudal regression, and he had a sled-on-sled impact, called the trainer over, he's on his side, he couldn't get himself up, no head or neck, intact primary. Mike Cortez, our trainer, got him up and pushed him to our door, and he was complaining of terrible pain, just intense pain at the knee and below. So we assumed, without any type of distracting injuries, that he had some sort of fracture below the knee. And so we got him extricated out of the sled by cutting his straps, by removing his case, by being on each side and lifting him right into his wheelchair, and then we splinted him in his wheelchair. And every time we splinted him and we dropped that leg down, he absolutely was in terrible pain. And we found so we kept splinting moving forward with SAM splints, towels, right? And finally, a foam roller. If you look on the chair, you can see a foam roller that is literally holding up his legs in a position of comfort, and that foam roller went with us in the ambulance and went with us right into the emergency department, and it went with him right into the operating room for his fractured femur. He had a fractured femur that we actually, all of his pain was referred down below his knee, right? And so I was quite surprised by that, but we had an indication that there was an injury higher than that, because every time we would try and move him, we had to readjust him to support his upper legs. Well, why is this important? He can't straighten his knees. His knees are stuck at that level, right? So if we were trying to get him off the ice on a board, we'd have to support his legs just like they are right there. We need to know that, be prepared for that. Our sleds, you can see an example here for a double amputee. It's like a prosthetic, and they're in tight. For individuals who have residual limbs or sound limbs, they're strapped into the nose piece for protection with the same type of these buckles, these M2 buckles. And these buckles can be really difficult, and they can also break or not open up. So we are always prepared to cut straps. And for sled hockey extrication and para ice hockey extrication, there's two kind of methods to do it. After you take a look at your scene safety. When we practice this, this is our athletic trainer, physical therapist, Mike Cortez, at the head of one of our volunteer athletes who volunteered to do this with us yesterday. And so we use the sled, right, to control the lower extremities. And we think about this, especially in people with spinal cord injury. If you have spinal cord injury, right, we can keep the legs in control by keeping them in the sled until the head and chest in spinal motion restriction are secure on your method of extrication board or scoop. You can also take that sled off in a side-lying position if it's the right thing to do, and they're halfway out of the sled. But the sled is an excellent tool in rolling and controlling the lower extremities. And we usually use a 6-person technique where the first person comes to the head, does your look, listen, feel, A, B, C, D. What is your underlying disability for this individual? Hey, if I didn't know, I'd say, is there anything else I need to know besides limb loss for you? Will you be able to bring that leg down if we have to roll you on the board? You can see 2 people here at the chest. You can see 2 people on the leg. So there's your 5-person, that's 6-person. Controls the lower extremity and takes the shield off of the and the buckles off by snapping that under the direction of the person at the head. And so then you would see they would roll, and you can see these 2 pictures of the fantastic EMS team at the rink sliding that sled off like a shoe while that 6-person controls the leg and then brings that leg down after we have the head and torso completely immobilized and set. And we've been practicing this for a while, and you may not have, the opportunity to have safety features like these great shoes and everything with a great extrication method off the ice. But you can, if you have a board, these people can be rolled onto that board, and you can even use a strap and then do a drag in. And we've done multiple things thinking about how to move someone from the ice to the ambulance or to the locker room, to the dedicated area for assessment. And we've been practicing this since Sochi, when I actually didn't have gray hair, since 2014. So with that, that's one of the ways that we like to do it, and we practice this. And Canadian team physician and I we've practiced this together. And anytime we're together, we have collaboration with the EMS and on-site ring personnel. Well, now let's move on to talk about something that no one ever wants to experience, and that is a cardiac arrest. And whether that cardiac arrest is in a para-athlete, a coach, or someone, or rink staff, it's so important to know that you can take that personal pause, make sure they're seen safety. Know that if it's in an athlete and game scenario, that there's an EAP that you've talked about before, and you go to that athlete and you've got that simultaneous 10-second look, listen, feel. It's ABC, and if there's no response, it's AED, EMS, and high quality CPR, because survival depends on it. 7 to 10% decrease every minute if you're in a shockable rhythm, right? And the most common cause that CPR isn't started or AEDs aren't deployed quickly is there are agonal breaths and there's still some movement. And we experienced this, sadly, in Dawson Creek earlier this year, not in an athlete or staff member, but in a rink member that we were first on scene for a witnessed cardiac arrest. And as we were getting AED and starting CPR, one of the assistants kept saying, well, she's breathing, she's breathing, she's breathing. But those were agonal breaths and agonal movements, and they're the most common reason cardiac arrest is not recognized. And it can delay high quality CPR. AEDs are so important. This is one of the famous, this is the only study I'll share. This is outcomes of rapid defibrillation by security officers after cardiac arrest in casinos in the United States. The United States has a 7 to 10% out of hospital cardiac arrest success rate, survival rate. Guess what it was for people in the casinos? 74% who received their shock within 3 minutes of a witness class. 74%. So that means that some of these people probably got up and kept gambling. I'm kidding. But my point is, that's the most important. Rapid CPR identification. The security guards weren't medical professionals. They knew how to use an AED, and they're everywhere and see everything. So they were there like that. And if they're in a shockable rhythm and they were shocked within 3 minutes, 74% of them survived. So what do we do with our athletes? What do we do with someone in a sled or in a wheelchair? Well, there are some steps that you can use that can help this incredibly stressful situation. And what we'll talk about now are 6 steps here, and there's a fantastic video that I'll link people to. And the first one is put on the brakes, okay? And of course, sport chairs don't have brakes, right? But if you're in a regular day chair, you put on the brakes, right? You create space, and then you need to get the person tilted and tipped back in a safe manner, right? Where you're safe and that person is safe as well, and then slide out of the chair, right? And then you start the assessment in CPR, because you can do the assessment, obviously, if someone is secure in their chair and sitting up. And if it's a power chair, right, you can actually use the tilt function in that power chair. It's much more difficult. You really want a good flat position for high quality CPR, because CPR needs to be high quality to actually be effective, right? And so wheelchair specific considerations for sudden cardiac arrest: lock, tilt, compressions, AED. So the acronym is lock, tilt, pump, and pad, right? Lock, tilt, pump, and pad. And there is a fantastic video that I encourage people to look at, right, and think about, that was put out by Dr. Asif from University of Alabama, Birmingham. I'm going to leave this up for about a minute so that you can take this QR code and get it into your phone and really kind of reach out for this. This is one of the most terrible potential situations that could happen, and we always kid that emergency medicine physicians spend 90% of their time thinking about the 3% of the things they never want to see, so that if it actually comes through that waiting room door or ambulance door, that you've had that simulation in one of the most powerful simulators that is out there, your mind, and you can just go, okay, all right, I've done this before, I've thought about this before, I know we can do this, I know we're going to be able to communicate and operate in a high functioning team. So with that, our take home points. All right. Oh, and I'll mention about how we would talk about this in a CPR and a sled as well at the end. So our take home points, really truly, ABC, expand that D, that underlying diagnosis or disability is so important to know something about. If you don't already know the athlete, that we talk about it in the primary survey, which is designed to identify life threats. Like if there's a B problem, you stay at B until you go to C, right? Or you address that problem, right? Equipment extrication. A little familiarization goes a long way. And I, when I came in, I knew obviously nothing. And who were my teachers? Well, the athletes were my teachers. And then when I would go to the National Veterans Wheelchair Games or the Winter Sports Clinic, again, the veteran athletes were my teachers, right? Hey, if I had to get you out of this, right, what would be the best way? How can I help you? Boots on the ground, right? What can I do to help you, right, if this would happen, right? And then the worst case scenario, sudden cardiac arrest, right? Lock, tilt, pump, pads. Lock, tilt, pump, pads. And for sled, get flat and get on the chest, right? So for us, we talked about this. For someone who's a double amp, and we have more, we have more than one person, right? We don't care that they're in the sled, because we're just going to take that sled, roll it up, a little bit of forward flexion so they're not hyperextended in their lumbar spine. And the other person who's doing the look, listen, and feel, if it's cardiac arrest, we've got scissors, you tee the jersey, cut the pads, helmet off, and you're on that chest asking for help, AED, and you do your high quality CPR, follow the AED prompts, and then move through, hopefully, to a successful resuscitation. So with that, I hope that this was at least some educational and in a way that we really think about how to take excellent care, just great comprehensive care of these athletes in a team setting. And with that, I'm grateful to be able to share a sport that is just incredible to me. And as I said yesterday at the practice, man, it just never gets old watching these guys practice and play. So thank you so much. I appreciate it very much.